Well, we tend to have a kind of a slow start as we do introductions. So I'm going to get started. And by that time, chances are folks will have all logged in by then. So welcome to the Best Practices for Co-occurring Disorder Integration series. This one is called Intake Screening and Assessment. Uh, Today's session is brought to you by the Great Lakes, Northeast and Caribbean and Northwest Addiction Technology Transfer Center and the Great Lake Mental Health Technology Transfer Center. And this is the fourth in a series of 5 trainings. Last training was organizational structure and service environment. And my name is David Jefferson, and I'll be the host today. If anybody has any difficulties, just put something in the chat box and I'll try to help you get logged in if that is the case. At the bottom of your screen, you have a chat box and a question and answer box. We may take a question or two as we go along, but chances are we're going to kind of reserve most of those to the end of the presentation. But also feel free to use the chat box for any comments as we go along. I also wanted to recognize that the TTCs, which are the Technology Transfer Centers, we have both addiction, mental health, and prevention. There's also a tribal and Caribbean TTC. These are all sponsored by SAMHSA, which is Substance Abuse and Mental Health Services Administration, which makes possible these trainings that we're presenting here today. For everybody that's here, you'll get a certificate for today's webinar. You don't need to do anything. Those will come to you automatically. However, if you're part of a group of folks, drop us an email and let us know the name and the email address of the other folks that are with you, and we'll make sure that they get that certificate too. And I'll also put this email address in the chat box in a few minutes. So next, I'd like to introduce our panelists today. Michael Chappell is an assistant professor of clinical psychiatry at the New York State Psychiatric Institute Division of Substance Abuse Disorders and the Columbia University Medical Center. He's also the director of the Northeast and Caribbean TTC. Welcome, Michael. And next we have Denna Vandersloot, who is the co-director of the Northwest ATTC. Denna's been providing DD-CAT assessments and coaching to providers in Washington and Oregon for over 10 years, has extensive experience doing motivational interviewing, integrated treatment, and expert. And our guest today is Linda Grant. She's the CEO of Evergreen Recovery Centers, which is an integrated behavioral health organization with 9 locations serving 5 counties in Western Washington. And now they're integrating physical health care as well. Evergreen Recovery Centers offers a full continuum of care, including acute medical detox and residential treatment to outpatient clinics, jails-based services, and intensive case management for pregnant and parenting women. Ms. Grant holds a master's degree in counseling psychology, is a licensed substance abuse disorder professional, and has 48 years experience. And Linda Grant and I go back many years. She is well known in the state of Washington, so it's great to have you here today, Linda. And I think with that, I'll turn it over to you, Denna, and I'm going to bow out for a minute.
Helps if I turn on my microphone. Thanks, David, and good day to people from, it looks like, all over the world as I watch the chat box. Just to start off, just wanted to take a minute to just talk a little bit about where we've been and where we're going. We've been really organizing this webinar series around the 7 dimensions of the dual diagnosis capability and addiction treatment and mental health treatment indexes. And we started off with talking about the program structure and milieu and training and staffing. And I often think of those as really the foundation. Like, what do you have to have in place to provide co-occurring disorder treatment? And now we're really getting into what I think many people think of kind of the meat of treatment. So what does assessment and screening and treatment and continuity of care look like? So today we're going to be talking about screening and assessment. And there, I guess it does work. Our agenda for today is to spend a little bit of time talking about what are the components of screening and assessment, kind of the discrete components that really strengthen more of a co-occurring disorder approach. We're going to be talking about some specific strategies that programs can implement to enhance capability. Linda will be talking about what is it actually like to implement these different protocols and strategies. David and I both had the pleasure of doing a DDCAT review at Linda's program many years ago, and we were very impressed with all that they had been doing and have done a lot since that time. So she'll be talking about what does it look like in an actual, or several programs actually, that she's the CEO of. And then we'll have some time for questions and answer session towards the end. We've tried to time the content so that we'll have time for that. But I wanted to start with this, why is screening so important? And part of it is this idea that, what we know from the National Survey on Drug Use and Health is that only about 7 to 10% of individuals who have co-occurring disorder treatment actually receive services for both or however many disorders. And so screening is really key. I like the analogy that it's really like the first domino in a cascade of services. And if you don't do screening and assessment, then it's hard to really provide the treatment and the continuity of care. So it really starts with screening and assessment. And taking a look at, SAMHSA actually looks yearly at programs, and this comes actually from their national survey that looks at substance use disorder programs to say, well, what does it look like out there? How much screening and assessment is actually happening? And what they found is that in kind of primary SUD programs, about 96% are screening for substance use. And I think it's something like 93 are doing full assessment around substance use. So I'm always kind of a little curious of what's that other 4% about? But it might be how they're defining it. About 75% actually screen for mental health disorders, and 55% of the programs are actually providing full psychiatric assessments for mental health with diagnoses. So that's kind of what it looks like. This is data from 2018. So we're curious about, for those of you who are on our webinar today and actually are a provider, Meg is going to launch us a poll. And once she gets it up there, you can actually select, this is one where you can actually select several different selections. So thinking about all of these statements, is it actually true for your treatment program? Do you routinely screen? And when we're talking about the other disorder, if you're primarily a SUD program, do you screen for mental health or vice versa? So just giving you a minute or so to input your answers. And when we're talking about treatment readiness, it's like, do you do some kind of screening? Maybe it's only a question or two to really assess a person's treatment readiness for mental health or substance use disorder. I mean, with some programs, I know I've recently been doing some DDCAT reviews, and it might just be a question. Are you ready for treatment? Or and others do formal instruments. Looks like we got quite, and we probably won't get to the full amount voting because we recognize some of you aren't providers. So maybe let me know when we're kind of at, okay. Do you have the viewing? Right. So it looks like about 57%, really close to actually that graph, right? I guess a little bit under are actually screening for the other disorder. About 23% are actually individuals receive a full assessment, and about 10% on treatment readiness for each of the disorders. And there. Are people seeing the results? Are they up on the screen? Okay, it's hard to see from this end. Well, thanks for doing that. It gives us kind of a sense of where people are at. And that's what we're hoping to do, is just give you all some ideas about some possible strategies. So I'm going to be talking about screening, and then Linda's going to jump in and talk a little bit about her program in screening. Mike will then be talking more about assessment. So keeping in mind, when we're talking about screening for mental health and SUD, it's really to determine the likelihood that a person has a co-occurring disorder. Not necessarily that is it to establish the presence of a specific type of disorder. But it kicks off really that there is a need for more in-depth assessment. I like to think about this, and when I'm training an expert about, if you go into your primary care or a physician's office, they take your blood pressure. It's a screen. And even if the score is high, it doesn't necessarily mean you have hypertension. It just means that you need further assessment. So with screening, keeping that in mind. And when we're doing screening, you're really thinking about kind of three essential elements of it. The first is intent. Like, are you using screening to determine if there's a possibility of a co-occurring disorder? Early on when I started doing some of these DDCAT reviews, what we found is sometimes people were using screening to actually screen out people before they actually got in the door. So they were asking questions on the phone. And which really kind of goes against that whole no wrong door policy, that you're wanting to screen and to do it as a way to get people to the services that they need, even if those aren't actually within your facility. The other step in the process is really, is it a formal process? Do you have a standardized process protocol for doing screening? And that could be a series of questions that are part of, say, an ASAM assessment. It could be formal, standardized screening instruments. But it's like everybody actually receives the screening, not just kind of clinician determined. And the next one is really early implementation. You're wanting to screen early. In the updated co-occurring tip 42, they talk about, I think the recommendation by that committee is that you also screen annually. So screening initially and then annually if you have these clients over a long period of time. So what are you screening for? And this is really thinking about what are the different areas of screening. The first really being client safety. So looking at risk of harm to self or others. Also looking at the risk for being in an environment or experiencing physical or sexual or emotional abuse. In the recent DDCAT, I've seen a lot of programs actually using this Columbia Suicide Severity Rating Scale that's actually built into their EHRs. And this isn't an exhaustive list of screening tools. These were the ones that were included in tip 42. Most of them are available in the public domain, so they're free of cost. And so that's just one, part of the reason that they selected these particular instruments. Of course, there are many out there. Then you're also looking at past or present mental disorders. And this is where you might be using more of a general form like the mental health screening form or the modified mini. There, of course, are also the screening forms like the PHQ-9 for depression or GAD-7 around anxiety. I see a lot of programs using those. The ASI is on here, and it's kind of like, well, some programs that does have a section on mental disorders, so some people use that as their screening tool. GAIN-SS is one that we often see used. At least in the state of Washington, we've seen a lot of that. I think the state actually influenced that. And I'm sure in other states, there are specific instruments that are recommended. And then, of course, if you're, whether you're an SUD program or a mental health program, you're also screening around past and present substance misuse. And so you see here some different possible screening forms that could be used. And then trauma is another important area when we're thinking about co-occurring disorders, because As we all know, there can be people who don't have, a mental health disorder per se, but have had significant trauma in their life. I often think this was actually a friend that I had, and she went to treatment, I don't know how, probably 7 or 10 times. And it wasn't until about her 8th treatment experience that somebody actually did an assessment around trauma, or a screening around trauma. And she had probably one of the most extensive trauma histories of anybody that I've known. And, it was really when things started to turn around for her, because somebody identified that how much trauma she had and began to really started to address that. The next step is really looking at the level of care. Mental health programs often use LOCUS. Substance use disorder programs, many use the ASAM. Okay, so really assessing and screening for the level of care needed. And then functioning and impairment, and the World Health Organization has an instrument for that. So those are some of the areas and possible tools. All of these are, most of these, not all of them, most of them are either the link to access them is in the tip 42. And so what are some strategies actually around screening and enhancing it? Well, the first is actually to routinely screen for, if you're a substance use disorder program, for mental health. And you can use a standardized set of questions. So it might be that you're using a biopsychosocial that's looking at dimension 3 and has a lot of questions underneath that. Or it can be these standardized screening instruments. I tend to lean a little bit towards the standardized screening instruments, because what I see with that is that then you actually have scores and cutoff scores to help inform the next step of the process. As well as you can use those scores to actually look at, what are the types of issues that many clients who are coming into your program are experiencing. Do you actually have a screen to assess risk of harm to self or others' trauma? So basically part of this is looking at it and saying, do I have the screening instruments? And another piece is really around, like, which ones do you select? And I think I'm going to kind of click all these in. I think a big piece of these strategies has to do with, yeah, you could spend a lot of time and screen extensively, but it's really looking at your population, programs that really look at their population and decide which of these screening instruments are probably needed most within their setting. So it also helps you to start collect some of that data. Like, what kind of services do we actually need? If we are administering and we're finding, like, we're using the PHQ-9 to look at depression and our scores are really high, that might really inform what kind of services or who you need to make connections with if you aren't able to provide them on site. And probably all of this goes into really having a screening protocol. So if you have screening tools in place, what are the cutoff scores that you're using, and what does a particular score mean? Does it actually kick off that somebody, I remember seeing this years ago, that people would have positive screens, and then you'd say, so what happens next? And people wouldn't, oftentimes people hadn't even received the training around that particular screening instrument to know what actually a particular score actually means. And so actually having this written up into policies and procedures can be a great way as training, and making sure that new staff actually get trained on this. And then if somebody's positive, what is the next step? And how does it actually get documented in the chart? Like, is there a way to continue to track this? One strategy that I recently saw, that program that was really impressive, is that they were using the PHQ-9 and the GAD-7, and they used it at, during assessment, but they continued to use it to monitor progress. So they actually had a way to track, were people actually improving in these areas? So I think that's another thing about using a screening instrument with strong psychometric properties, is that you can also use it to really monitor outcomes, and use that in a variety of ways. Of course, first and foremost, to improve services, but also to, for funders, or to really guide what you actually offer. So those are a few strategies. Now we are going to hear from Linda a little bit about, Linda, how have your programs gone about doing the screening piece? Oops, you're muted, Linda. We need a official universal muted sign.
My programs are primarily substance abuse disorder programs. And so we started out with, we've always had a fairly diverse staff. But we started out primarily with people that have chemical dependency backgrounds and not necessarily a lot of ability to provide full services. So first of all, it was really hard to get people to understand that because they screened and identified a problem, they didn't have to fix it. And so we developed, we began with the SS or the GAIN SS because the state mandated it. And that was a political thing. It really was not clinically driven. There was some politics at the state where they wanted to put us under mental health because they believed that everybody who had a substance use disorder had a mental health problem. And people like me were pushing back that that's not necessarily the case and not our experience. But it was not bad information to have. And so it was in the data set that we had to submit to the state in order to be paid. So there wasn't much choice. You did the GAIN SS. And the problem with it was garbage in, garbage out, and there was not a lot of forethought into the answers, or if you ask a person with no training in any mental health screening at all, whether someone is high or severe, they're guessing. And so I don't think we gathered a lot of data, but that was particularly valuable in the state. But each agency had a different capacity to handle that data. On an individual level, we would put that in the treatment plan. And we did happen to have a number of people, at least a few in the beginning 20 years ago, who were duly licensed, like I am, that have mental health backgrounds and chemical dependency. And so we put it into the treatment plan, even if we were not the provider. So if they indicated some high needs, we might refer them to the mental health center for a full assessment. And so that one was fairly easy to implement. And we were in the process of trying to become a one-stop shop anyway, which I can talk about later. But that one was easy. Recently, in the last 3 or 4 years, we have started collecting the PHQ-9. And I do that because as we were going into a managed care environment, they want to see value added. And it's kind of stacking the deck for people with substance use disorders, because we all know that if you get clean and sober, fewer are depressed. And so it would show the importance of chemical dependency treatment on mental health and the corrective action that happens when someone gets into recovery. And so we collect the PHQ-9 at admission, and then we collect it again at the end of IOP, intensive outpatient, and we collect it again at discharge. The residential programs collect it at the beginning and end of their treatment. And our detox doesn't collect it at this point, but we have mental health professionals there that could, and we may do it in detox. We're trying to be very consistent, but that requires that they put that into a treatment plan, and I can talk about that later.
Thanks, Linda. And Mike, I'm sorry, I think I advanced your slides accidentally, so.
Sure, let's see. This is me, right?
Yep, I think so.
All right. Hello,
Take it away.
everyone. Good afternoon, good morning. So as we move into addressing routine biopsychosocial assessment, I want to kind of bend back to the last point that Denna made around screening protocols, because as we move through this clinical workflow, so to speak, I like to think of this along the lines of the HIV cascade of care, for those of you who are familiar with it, where the suggestion is that 90% of all people living with HIV will know their HIV status. They'll be screened and identified. 90% of all people with diagnosed HIV infection will receive antiretroviral therapy, so they'll be treated. And 90% of all people receiving ARV will have viral suppression. And so it's the same sort of consideration here. Those are obviously very lofty goals, but why shouldn't we aim high? We want to be able to identify most of those people with a co-occurring mental health or substance use disorder. We want to make sure that most of them get assessed and treated. And we want to make sure that in doing so, most of them have improved outcomes. And so similar to that domino, visual, it's the same type of thing. And that's why the screening protocols are really important, because in my experience doing DD-CATs and DDCMHTs, there were a lot of programs that were using the screens. The screens were in the folders. They were, whether it was an EMR or not, the screens were there, the questions were asked, but they weren't being scored. They weren't triggering an assessment, and they weren't carrying through. They were just there because, either they had to be there from the funder's perspective or whatever the case may be, but they weren't being used in the proper way. And so I really would encourage people to consider, not only are you using them, but are you scoring them? Have you thought that through? Do you have policies and protocols for those who score positive, what you expect the outcomes to be? That's a really critical piece there. And so as we move forward and we think about what that means for assessment, the idea is that all clients who screen positive, according to your protocols, are assessed for mental health and substance use disorders. And so, everyone has all these, all of you as providers and all the programs that are participating here have their forms and their documents for biopsychosocial assessments. And what we're looking for is a further explanation of the presence or absence of a co-occurring disorder. As Denna said, a screen is just an indication that they are likely to be present. They're not 100% accurate. They're usually about 80% accurate if they're validated, and the ones that we recommended are. And so you want to explore that further and make sure that there's room. And most of these biopsychosocial assessments do have room for exploring mental health and substance use disorders, but that's where the policy or protocols come into play, because if they don't exist, many clinicians who may be uncomfortable, not prepared, haven't traditionally done this, will sort of just gloss over that piece and not, like, we all know that an assessment is about as good as, the amount of probing and questions and the way that you go about doing it, because it's largely open-ended and qualitative. And so making sure that that's thoroughly explored in an assessment. And in doing so, really determining the patient's readiness to change is part of that. And this all has to do with that thread that we're going to pull through, because the treatment recommendations that ensue really should take that into account. I mean, one of the common things we heard was, we want our clients to go to AA or NA, but they're resisting. And it's like, well, if they're pre-contemplative or contemplative, attending self-help groups is really a down the line, kind of intervention, and we have to consider that. Identifying strengths or problem areas. So an assessment is about a lot more than just behavioral health, and making sure that that's thorough, because many of those issues around housing, employment, family, relationships, and all the other things explored in an assessment really can affect the processes of recovery from mental health and substance use disorders. And we all know that. So how are we exploring that? And then engage. Also, this is an opportunity. The assessment is an opportunity for engagement. If you're talking about motivational interviewing and client engagement, this is really a great opportunity to do that. And I think one of the really key points here, if we're thinking about that thread and that kind of cascade of care and that 90-90-90 lofty expectation or goal, we're really thinking about, I think the most tangible thing you can think about in the way of an assessment is that if you have a positive score, if you're in a substance use program and you have a positive screen for mental health, and that's adequately explored in the assessment, then is there a diagnosis or a rule out recorded? And that's the way you can really think about how you can systematically pull that thread through. If there's a positive score for a screen, there's not much in the assessment about the mental health in terms of further exploration, and there's no diagnosis or rule out, or for substance use, for example, in remission or whatever the case may be, then it would almost appear as though it wasn't sort of properly vetted all the way through. And so I think that's something to really think about. And then if you participate in our next webinar and we talk about treatment, you'll get more ideas about what we mean around this 90-90-90 piece and this thread that we want to make sure we pull all the way through the clinical continuum. In terms of ensuring routine assessment, you know, obviously identifying the staff who can do that. You know, not everybody in-house can do that. There are certainly restrictions around who can determine diagnoses and record them and whatnot as far as licensed social workers. I mean, certainly in New York State, you know, where I'm from, in upstate New York, there's a lot of challenges attracting, you know, certain types of clinicians who can perform the diagnosis and record the diagnosis. And so, you know, CASACs or certified addiction counselors might be limited in what they could do. So there might have to be partnerships put in place, MOUs with other agencies who have these, you know, dual capacities, or make referrals to those agencies to do those sorts of things. Again, ensured diagnoses are noted in the record, but I really wanted to emphasize that in pulling in terms of the connection between screening and assessment. Use integrated assessment instruments. That's a possibility. It's certainly probably beyond the capacity of many programs. As I said, a lot of biopsychosocial assessments, you've been using these forms for a long time, but it's certainly worth looking at some of these elements like the GAIN, the locus, the ASAM, to see what's in there and to see how well some of those advantages are reflected in your current, you know, your current assessment protocols. I think the idea of sort of changing an assessment program, or I think what happens often is we add to it because we can't really change. And then the more we add, the more of a burden we put on. And at the end, the reality is that we have the ability to go through and pare down redundancies and all that, we would, but it's just much more complicated to do that than it is to add. So that's always a challenge. I recognize that. There is this notion, and I think in the data, this is what we were sort of alluding to in the poll, is thinking about as part of this assessment whether or not you can do anything in the way of a formal stage-wise assessment. And the last two particular questions asked if you looked at client readiness for mental health and substance use. And we'll talk about how you could potentially do this. But it's a hard thing to do, but the idea is that being aware of the stage of change, the trans-theoretical model, and where that client is really helps you to think about, in particular, what you're doing when you're treatment planning and providing treatment. It's really important for that. Sometimes it's misinterpreted to mean that you're going to develop some, you know, stage-wise treatment program, which is really difficult to do, but certainly figure out a way to make sure that it's a consideration as you move forward with the assessment, with treatment planning and treatment provisions. And so in terms of strategies for readiness to change, you want to understand where they are in terms of both substance use and mental health disorders. And they're likely going to be in two different places. I mean, often with regard to each disorder, often what we find, if they are showing up for treatment in a substance use disorder facility, even if they're mandated there, they're sort of aware of why they're there and what's going on. And then when we try to engage them in a conversation around the other disorder, it's a lot for people to handle. Well, I have a substance use problem. Now you're telling me I have an anxiety issue or a depression issue. And so oftentimes they'll be a little bit more receptive to one versus the other. It also depends on their past treatment experiences, but don't expect they'll be in the same place with both disorders. If you can, there's the option to use formal comprehensive measures to assess stages of change. The two most popular ones in the way of assessment are the Socrates, the Stages of Change Readiness and Treatment Eagerness Scale, and the Eureka, University of Rhode Island Change Assessment Scale. Again, these aren't necessarily short and they add burden to the intake process, but you can look at them and see what they're getting at and compare it to some of your existing processes and see if there's an opportunity to integrate elements of that. Providing training to staff on motivational interviewing in stages of change. I think most folks in the substance use treatment field know a lot about the trans-theoretical model and the stages of change. In the mental health field, I think it is also common knowledge, perhaps not as common knowledge, but it's certainly getting there. But those stages of change are very important to understand, to know about, and motivational interviewing laid over the stages of change is a way to think about engaging clients based on the stage of change, that they're currently at. How do you build rapport, engagement? How do you move people to develop discrepancy, create ambivalence, address ambivalence, etc.? Focus on behavioral change goals, and all those various tools that MI sort of offers in moving the client along. And then to whatever extent possible, I'm always sort of even cautious in my own recommendation around this, but thinking about some type of phased approach to treatment, or some ability to think about how you can match treatment services based on readiness levels. I gave an example before around, it isn't one size fits all. So if you're doing a lot of the same things with your clients and they're at a variety of different stages in terms of their treatment readiness, you're going to get a lot of different responses in terms of their ambivalence, or what some people may even view as resistance. So that's important to think about. But if it's not the Socrates, it's not the Eureka, there are certain, questions that you can ask in your assessment, as the ones laid out here on a 10-point scale. How important is it to change your substance use? How sure are you that you'll be able to make this change? How important is it to you to change your mental health issues? And how sure are you that you'll be able to make this change? And you can get really just a good idea. It doesn't necessarily link per se in the same systematic way that the Socrates or the Eureka does to a particular stage of change, but that's also not necessarily crucial. Just really understanding, is someone pre-contemplative, contemplative, or are they preparing and moving towards action? I mean, it's really, it doesn't have to be highly specific. Just getting a general idea of where they're at will be really helpful in terms of how clinicians engage folks in an assessment and then move on in terms of treatment planning. Another thing is documenting mental health and substance use history. So the assessment and the intake routinely describe past history of both disorders, but certainly the other disorder, in terms of adequately exploring it and looking really importantly at the chronological relationship between both, to inform differential diagnosis as well as interactions between the two. So I think we often get ourselves, I know New York State is particularly challenging around this, because we actually have two separate service systems here, the Office of Mental Health and the Office of Addiction Services and Supports, OASIS and OMH, which regulate their, substance use and mental health respectively. And so, we have licensing barriers and all of that. And we also have, thinking about, often get into this thing where we think of which one's primary, which one's secondary, which one came first, the chicken and the egg thing. And we get all wrapped up, and we forget that regardless, there is a whole nother ideology around this in terms of what's happening chronologically over time between substance use, understanding to be able to inform the differential diagnosis, and in particular, how they tend to interact with each other. And so looking at strategies to enhance that documentation, making sure that in the assessment there's room for both. The initial evaluation process looks at dates of onset, course of both illnesses, the interactions during periods of abstinence, treatment, and institutionalization, etc. Use assessment instruments where possible, structured to connect identified symptoms to periods of abstinence, looking at these things more deeply. And then also educating staff in terms of doing assessment on DSM-5 differential diagnosis guidelines, and thinking about how you could further tease this out. Finally, explore beyond, behavioral health. The assessment, we often focus much on mental health, substance use, especially given whatever our primary charge is, but looking at the presenting problem and what the interactions are there, and then all of these other things that I'm not going to read through, which typically most assessments do have domains for this, but really looking at how do our clinicians and how do our program tend to address these domains, how consistently, with how much depth, and also in what way is the relationship between some of these domains and mental health and substance use explored. As again, this could be a method of engagement as we identify, a lot of clients may not come in thinking, or acknowledging they have a substance use problem or disorder that needs to be addressed, but they may be able to acknowledge that they have other goals in treatment and that their continued use is impeding their achievement of those goals. At this point, I will pause and give the floor back to Linda for some of her insight, how she's addressed some of these recommendations and challenges in her program.
There, unmuted. You know, everything is hard when you start doing something new. And so I have this, this indomitable spirit that it doesn't matter how hard it is, we're going to do it anyway. And that helps us get through. And I think that's what you need when you start doing something different. And then there are a lot of people who do not like change. And I find that in our staffs, especially, they throw their hands up when you say, we're going to do something new. Then there's people like me who can't stand the same and love change and hit that max on, well, I think it's the Edwards personal preference schedule. And so I think you kind of have to walk people through. And we certainly did not have a main game plan in implementing more integration and providing services that are dually capable, other than the fact that we saw the clients and knew that about 25% of them would drop out of all services if they were asked to go somewhere else. And to me, that told me that we have to have more one-stop shopping. You know, we've got to be a place that serves that person more wholly. And so having only a substance abuse specialty had some real strengths. But one of the weaknesses was that there are a number of our clients, and particularly in some of our specialty programs like pregnant and parenting moms, where they get into this high intensity treatment because they have very complex situations and often huge histories of trauma and often a lot of mental health disorders that occur with that. So we offer services that are high intensity, and I felt that it was important that we have the capacity to address the issues. Having done that, we started out with creating training programs so that we would have on-site supervisors. The only way to get the staff with the capacity to deal with all these things is to have the supervisors capable of doing that. We created tuition programs so that people who had their CD backgrounds and had some education would finish their master's degrees, get their licensing, and then bring that credential there, become a supervisor. And today we hire primarily people with out of graduate program internships that we have. So I think that's a really good way to get from point A to point B. And it has helped us then to implement the kinds of things we need to, because they're not as afraid of these tools and all the information they're going to uncover that otherwise they don't know what to do with. And so we have integrated individual counseling, and we started this with a drug court contract that the drug court clients were being referred to treatment with private practitioners and not doing well. So the court came to us and said, would you do this? And we had some counselors who could do that, were great mental health counselors. And what I watched were a lot of clients doing phenomenally well, very happy, very excited that they were getting individual counseling from a mental health counselor right there at the place where they had chemical dependency treatment. And that informed me that we should not just settle for that for drug court clients. And so then we started the process of putting the mental health counseling in, instead of a lot of individual counseling with a chemical dependency counselor. Their individual counseling was often with a mental health counselor to address their trauma issues, to address whatever else is going on, marital issues, family I'm a bad parent, anger. We had a domestic violence perpetrator program. They might go into that, so that we had the ability to address some of those on site, and they didn't drop out, because you will lose them when you say, go down the street to the treatment center down there, because that's a scary event for a client. That's all new people, they're unfamiliar, they know you, they want to be there. So that has been a piece of what we're doing. We, of course, also are mandated to use ASAM, so we are, and we like ASAM. It's not like we're having to do it. But ASAM is a wonderful tool for integrating that readiness to change and looking at where are they and taking the client where they are. And that's a good topic for mental health sessions. We also are now able to address with the PHQ-9 if they want to go somewhere else for counseling, or we have clients that are in counseling with private practitioners who then come here for an alcohol drug problem. They may work with them, but integrating and talking with that practitioner is really important. We have mental health counselors now available in our detox program, Clear Up, through our residential treatment, and our pregnant and parenting. Both of our residential programs have co-occurring capacity. So it's just making it available, and then the feedback you get from the clients is enough to make you want to continue doing it. Clients love it, and the results are phenomenal. And I was actually in a meeting, I'm fairly involved with politics, and I was in a meeting in Olympia where there was a representative from the courts in this meeting. And he said, oh, I went to treatment at your place. And he was one of our first mental health clients. So it pays off in spades. And it's really very exciting to have the ability to address the full spectrum of disorders in behavioral health in one place.
Great. Hey, thanks, Linda. David, I think we have some time for questions and answers. One of the first questions that came up on the chat, so maybe I'll start there, unless you have anything else to add, Mike, before we go into question and answer.
Nope, let's do it.
Okay. So I think this came from Julie, and she said, knowing that there is a high percentage of individuals with co-occurring disorders, is there any reason to not just assess everyone and skip the screeners? And Mike, Linda?
That's a good question. I certainly understand it from a resource perspective, but what I most often saw when I went on site and visited a lot of programs were at least programs claiming. Now, I don't, when you do a DDCAT visit or DCMHT, you don't observe live assessments. You don't even look at, records, because those are, that's protected health information, at least those kinds of records. But often programs would just say, why do we need to do a screen if we're doing a comprehensive clinical assessment on everyone that comes through this door? And that includes, substance use and mental health. And in theory, I think that would be fine if you can actually say that that's true. If you can say with confidence that is indeed what's happening. Even if there is always room in the biopsychosocial to explore the other disorder, but getting a sense for how thoroughly, how routinely, how comprehensively clinicians are doing that would be really important before you make a decision to forgo the screen. The screen helps to highlight the need for that, and sort of like, I almost usually think of it as like when back in the day when we had paper records, if you had someone who screened positive for substance abuse or mental health, you'd pick up their folder and there'd be like a little red flag on it, right? And you'd be like, oh, this is someone who screened positive. I know that I, have to thoroughly explore this. And so I think in the ideal world, if those assessments were routine, meaning they were consistently happening, and they were in-depth and they were thorough, and that happened across all your staff, you probably wouldn't necessarily need it. But even if you were doing that, you could, in theory, argue that potentially you would save some time as well if you were screening, and you could eliminate that in-depth assessment of the other disorder for 20% of the clients, but I recognize that the assessment's still probably going to take almost as long anyway. So there might not be a whole lot of resource savings there. So I think it's just a matter of whether you can say with confidence that that's routinely happening. Dina, I don't know.
Yeah, I don't have anything to add. Linda, would you add anything to that?
You know, I think that it's overstated how common mental health issues are, because there's not an address, they don't address severity. Every one of us could benefit from counseling, and many of us have. And part of my requirement when I was getting my master's degree is to be a client. And I have been a client throughout my life. That doesn't mean that because you have issues that you have to have, that has to be part of your recovery in whatever your identified issue is. Now, having said that, I think that there's a real efficiency to doing a screening, because then that helps you sort out and address the ones that are at high, from my perspective in providing substance use disorder. I'm looking for people who are at high risk of relapse because they have not addressed their mental health issues. And it also is a function of the setting in which you're working. If you're working in an outpatient setting where you're getting primarily drunk driving people, you may not see as many co-occurring disorder folks as you will see in a co-occurring disorder pregnant parenting mom program, where 80% of our moms have domestic violence or trauma histories, sexual abuse. I mean, they come with a plethora of issues. So your setting will also drive the decision around whether you should screen or assess. Screening is expensive in terms of time, and it's hard to find the professionals capable of doing all that. So I think the assessment is that. And so screenings are very efficient to identify, should we go into this in depth? And I think Michael very adequately addressed that. So I think it makes sense to do a screen and then take that information, because a screen can be done in a few minutes usually. And then you take that information to decide if you're going to go in deeper. And then your assessment will guide you on what level of care you need to build into the next service. We all have service plans. You call them different names in different places, but you all have a treatment plan for the client. And that's where you build in some of those other things.
So we have some questions coming in. Dina, were you going to say something before I do some questions?
No, I was just, yeah, I wasn't sure if I was handing it back to you, but yeah. So David, take it away.
So I'll take them a little bit in order. And one came in, says, what is the best way to distinguish between substance-induced disorder versus an independent mental health disorder? Mike, Dina?
You know, I hate to do this to you, Linda, but I'd like to defer to you on this one, because you are the most clinical of the three of us. We sit in our seats today.
I'm a little rusty on this, but this is interesting. I was having a conversation with Claudia Black the other day, because she had a meth client who looked psychotic, and everybody wanted to get this fellow into a mental health facility, and they wouldn't take him because he was on meth. And so she said, can you take them? And I said, of course. So it depends on the drug, and that's where you really need to look hard at which drug they're using, and is crazy thinking is what I call it, but where you're confabulating, you're paranoid, you're not actually perceiving the world like you see with meth. And we see a lot of it. Up here, meth is as common as opiates. And so we see a lot of it, particularly in our detox. And so you do have to look at what drugs are going on in there in order to even make the first cut. Then after a while, if this person, and this is the substance abuse approach, if you have a person who after a couple weeks, 2 or 3 weeks, appears to have severe depression or severe anxiety, and the drugs that they're taking have probably run through a lot of their intensity, then I think you have to look at the mental health side. And so you really have to get a look at the person when they're cleared out of drugs. If they're not clearing out of drugs, you just are guessing, and you have to sometimes.
Thank you, Linda. So here's another question. I'll just keep them coming here because we got about 4 or 5 more minutes before we need to close up. This one is in particular about more information about a phased approach to treatment planning based on clients' readiness. This person works with a lot of court-mandated clients who are participating in treatment not based on their own motivation, but the motivation to stay out of jail. How might you address that?
I can say just a few on that. Because I hear this a lot from providers, and it becomes tricky because sometimes, and I think this is changing, but court mandated clients might be like that. It's almost like the court has mandated the level of care that somebody needs. Maybe not technically, but in many ways, it's kind of like you need to complete this. And so I think, this idea that, and I really think that that's the basis for the ASAM and the treatment readiness, that, a need at a higher level of care may be there, but if the treatment readiness isn't there, do you actually put somebody in an inpatient residential treatment service when they don't even see themselves as having a problem with drugs or alcohol or a mental health issue? And so then it becomes, do you start in a lower level of care, not lesser, lower level of care to actually start building motivation? And, so I think some of those where it's almost you have to like slow down treatment. I've seen lots of programs that do have phased approaches, but they're almost more programmatic. And so when I think about a phased approach, it's really, where is this person's readiness? And maybe you can't do that in a group setting, but can you supplement some individual sessions? So those are just some ways strategies I've seen people try to do that, to do a phased approach. Mike or Linda, what else would you add to that?
Thanks, Dina. Yeah, I mean, I think, we actually just had this conversation in a technical assistance consultation yesterday, with a treatment provider who was asking about mandated clients. And it's a motivational interviewing project. And so there was a lot of that sort of focus. But what we talked about was, a couple of things in terms of what that phased approach would look like. So, one piece of it would be, motivational interviewing, right? Like engagement, working on identifying and exploring with this client, helping them to focus on the various things that are going on in their life, perhaps working towards developing some discrepancy around their behaviors and things like that. For those of you familiar with MI, and Dina is more of an MI expert than I am, but I've certainly had my fair dose of it. And so, there's that piece of it. And in many ways, it even could be a distinction between, keeping someone in individual counseling and working on them that way, and then thinking about, well, are they really a good match for the group services, which I know is a challenge in substance use treatment because we're so much built on the group model in terms of billing and reimbursement. If there are group services, so that they're more perhaps focused on psychoeducation rather than, deep process or other evidence-based practices or, self-help or things that really don't match that stage of change or that readiness. And so individual counseling, engagement, exploration through motivational interviewing techniques, and perhaps some psychoeducation is just a thought. I mean, I don't think you're ever going to get to the point, although I've seen attempts at this, they're very complicated, where you have, I think, as Dina was alluding to, programmatic elements aligned with every stage of change or that type of specificity. But that would be what I would say there.
Some great answers, and the questions keep coming in, but we're kind of running out of time. And so at the top of the hour here, any final really brief comments before I move on to some of the closing pieces?
I just want to say one thing. that the research shows that the reason that persons start substance abuse treatment become irrelevant, and almost all of them are unwilling. So I wouldn't put too much on the initial presentation of the client, that you lead them to water and you hope to make them thirsty. And if you can keep them sober long enough, they begin to experience the pleasures and the reinforcers of not using, and then that motivates them further. So
Wonderful.
it's hard. It's a clinical judgment and experience. Yeah.
Well, thank you all today for presenting. I just put a brief survey in the chat box that'll also follow up tomorrow with the same survey link. So if people would fill that out, we'd really appreciate that. This slide set will be made available to everybody that participated. A link will be sent to folks. And also, again, if you were here today, you will automatically get a certificate for attending. And I think with that, the next training is on October 21st. It's called Best Practices for Integrated Treatment Planning, Service Provision, and Continuity of Care. And the advertisement for that will be going out fairly soon. So big thank you to Linda, Michael, and Denna, and a big thank you to all of our participants that were here today with us. So with that, we'll say goodbye to folks. Take care.